you. So next we have Arthur Jenkins talking about Bertolotti syndrome, evidence-based approach to diagnosis and treatment.
Thank you. So before I start, I want to just take a quick poll of the audience, if you guys don't mind. For those clinicians out there, how many of you are actively treating Bertolotti's patients? So what I'm going to do is I'm going to just talk a little bit about some of the history for those of you who are not familiar, because it'll put this into better perspective. Mark Twain said, "It's not what you don't know in life that gets you in trouble, it's what you know that ain't so." And if dogma is described as an established opinion, then rogma is wrong dogma, or poorly substantiated but established opinion. And Bertolotti's patients suffer from the rogma that lumbosacral transitional vertebrae don't cause pain. Now, what is a lumbosacral transitional vertebra? If you're not familiar with it, it is the hybridization of a lumbar and a sacral vertebra at the junction. It is a congenital anomaly that consists of multiple aspects of fusion of the processes between a lumbar formation and sacral formation. That involves oversized transverse processes, upsloping of the sacral ala, as well as underdeveloped discs, underdeveloped facet joints, and ultimately the pain generator comes primarily from the actual contact of the transverse process and the ala. This is present in about 10 to 30% of the population. Now, unfortunately, the most prevalent classification system out there in use is the Castaldi classification, which only measures, the only quantification is the size of the transverse process, which is not the tumor. It was only designed to predict the presence of disc herniations at the lumbosacral transitional level. It was not designed to predict pain, or in no place in the article did it say Bertolotti syndrome. However, in his conclusions, he determined that types 2, 3, and 4 don't get disc herniations, therefore they are not important. That makes up 80% of my surgical population. So these patients are underdiagnosed, but their pain actually comes from this transverse process ala interface. As a result, this has led to a general classification that these patients don't have a pain generator. And what I can tell you is, having treated more than 500 patients who've come to me from 6 continents, that the transverse process can be identified by injections into the transverse process, and that the typical presentation, they do very well with surgery that is targeted specifically for the different types that we have. We do resections for type 1, we do bilateral resections for type 2, we do onlay fusions into the transverse process if there's a type 3, which is rare, and the type 4s, it's a unilateral fusion. So the type is treatment specific to the classification that we redefine based upon the proximity of the transverse process to the ala, rather than treating the transverse process like a tumor. So if seeing is believing, believing is necessary for seeing, and if you don't believe that transverse processes and transitional vertebra can cause pain, you'll never see it, and your patients are begging for you to see them as they are.